going to be talking about ethics and medical legal with AI. Here's my disclosures, which are nothing relevant to this. These are kind of the things we're going to talk about, but you think about it, what we need in the ethics of dealing with all this probability goes back to Sir William Osler, who was talking about uncertainty and probability back in the day, but obviously we have much more things when you go up to, this is Dr. Peter Lee, who's in charge of the medical aspect of Microsoft. If you're ever interested in a good book that kind of reviews all these ethics, I would highly suggest this, but our previous authors have already gone through what is AI. Is it the artificial intelligence? Are we talking about deep learning, machine learning? They're all somewhat different. And in this we have the medicine and learning, the national processing, which I think Mo was alluding to before, and robotics. And these are going to have different ethical implications depending upon how much they interact with the patient. Some could be quite linear, as Ron was just alluding to, with like the robotics versus managing patient care in the office. And part of that also gets into the data science that makes this actually all work is also going to be logarithmically growing over time. And what's complicated now may be less complicated going forward with different things. But so this is kind of actually a review slide of what we talked about already today of what is AI? Are we talking about the machine learning, the robotics, voice to text, text to voice, et cetera. But what we really need to talk about is, for the ethics component to this, is how much is really being involved. Is it a limited data set, or as you migrate towards the right, these larger neural networks where you can have much more bias being built in. So if you look at this slide, it talks about machine learning, which could be on a relatively limited data set, being very focal, things for robotics or those type of aspects, versus on the deep learning where they're encompassing multiple data sets, and it's actually very little human interaction and more reliance on these data sets to interact with each other. The biggest part for the ethics, I think, can also be alluded to this slide. So on the far left, you see all the data inputs that go into it. And these different machine models then go in, get that data set, and then put whatever the algorithm is to then do the output. And here's where I think the rubber hits the road. One, where is that data coming from? The term "you are what you eat" is very much appropriate in this whole AI paradigm, because they may not have access to all the different data sets. You look at all of the QOD and ASR, that's going to be invisible to ChatGPT if it's trying to be doing what's the best thing. Now again, these systems can learn. If you put ChatGPT in the first time I used it, it was like, how do you treat a herniated disc? Actually, the first thing I put it was, what is the air velocity of a sparrow? And it said, oh, going Monty Python on me. I said, I like this tool. Anyways, but ChatGPT, how do you take care of a herniated disc? Going to put out a whole bunch of stuff. And go, ChatGPT, how do you take care of a herniated disc? Limit your search to anything that's been published in PubMed. It's a different answer. It's not using TikTok like we saw before, et cetera. But that's where those data sets are coming from. And a lot of the data is siloed. Certainly all the data that we have is somewhat siloed. All the data that's in United and healthcare and all those folks have all the different data. And the second part is the learning. So in that you go in, it has to be trained. So who's training? It certainly isn't us. Okay, and just we talked about some of the other things in medical healthcare policy, maybe training it, and maybe be tipping their finger on what is more important and what's not more important. And we need to be really cognizant of that before we get the outputs. Scott already alluded to hallucinations, and we talk about it. Yes, it's fine if you're ordering chop suey and you get the wrong thing. Yes, I did look that up. But when you're talking about with a patient right in front of you with a complex medical thing and it hallucinates, you're going to quickly lose trust, and it's obviously got ethical as well as legal implications thereof. And when you look at this slide, it says, well, what do you do when you see a hallucination, if you even realize it? And most of those, the light blue and the dark blue, talk about, well, I cross-reference it with other trusted sources. Well, what are those trusted sources? And if we keep going down this thing, we're not going to have those trusted sources. Rely on my own sense of instincts, which is exactly what we do in the OR now if you're using a robot. So that doesn't look quite right, because we've done this open so many times before. Seek verification from outside experts. Again, we're going down this thing. It's like more sophisticated information. It's like, well, I don't know much about coding, but ChatGPT, give me the codes for doing a T10 to pelvis with A-lifts, et cetera. And if you don't know what those codes are, say, oh, yeah, that sounds good, but it could be all hallucinations. So this is going to be an important part for cross-referencing going forward. Here are the current applications, imaging, analytics. We talked about this before. And there's obviously potential benefits for the patient for improving their outcomes, enhancing operational efficiencies, as Mo was alluding to before, putting things into Epic, et cetera. But what are these ethical considerations? First and foremost, we have to protect patient autonomy about doing. We're talking about huge amounts of data, but at the end of the road, we want to see what we're doing with that patient or who's interacting with it. The informed consent process, we already just went through that already, but it's informed consent both ways. It's also for the doctor as well. Are you going to be consenting yourself to be using these paradigms and like releasing some of your autonomy to interact with these patients going forward? Building trust, and I think that has to go both ways. These are coming out, obviously, and this is not an old person like me and a young person like Andy Chan. They're going to be different, but you have to still trust in it. And we also have to have our patients have trust that they can actually go to this. And one of the problems with these computers is when you're sitting there giving difficult information, I can see Zoe up here is talking like, Z up here, we're talking a big brain tumor or skull-based tumor. What's the empathy going to be that if they're going to be getting that information in silo? And it's kind of hard to message that information along. The impact of bias is huge. The databases that these large LLMs are getting from may not be from what's true here and may not be true in California, much less Africa and poor countries. Are they going to be using the same algorithms, and is it justifiable to say that's actually going to work? Is it equitable in its development? If we're using, again, who's doing that training? Is it equitable that they're doing it in completely non-biased fashion? And does it represent diverse populations? As I said earlier, if it's all on a small population that they did their training on, but it's not the population that you're being exported to, that's going to be difficult. There's huge privacy concerns. Some of this is very sensitive data. How is that going to be mitigated and pushed out? The privacy and confidentiality of the data that we have in our offices, is that going to go out to be large in training, and how is it going to be de-identified, which becomes increasingly more difficult. And there's going to be regulatory compliance. There's an FDA, I think there was like 75 different things that were put to the FDA, but only like half to one-third of them actually put in what their algorithm really is to do it. It was for a product, so it was a widget, but the AI that came to it was very kind of nebulous of where it came from. From the medical legal standpoint, this is also going to be huge. It's also very much evolving. The complexity is large. The accountability, again, just using a robot, robot doesn't, puts a screw in a different area. Is that because of me? I didn't, register the robot, or is that because the robot's got an inherent failure to it? Who's going to be liable for that? Is it the programming people that, put that in? And that's just for something relatively simple. Start getting into the whole diagnosis train of, cancer treatment with multiple medications, et cetera. That can be very difficult. So who's, quote unquote, whose fault is it? And unfortunately, as us as surgeons and clinicians, we're captain of that ship, which is a Navy term. We are the captain of the ship. And, but it's going to fall on us, but we have to figure that, we have to be cognizant of that when we start using these more advanced aspects. The regular importance of compliance, that, people are building these things, just like we saw Mo earlier, who's complying to the rules of how these things get put out, and then the overview. Intellectual property rights. Again, this is one of the reasons I think we have a problem with the databases, is that people are siloing their data because it's our data, and people have been somewhat reluctant to put a lot of this data forward. And until we get that trustworthiness that, it's going to be, quote unquote, greater good. But if you have intellectual property in that, then you're going to be, somewhat less to do that if you have a somewhat unique idea. Successful AI diagnostic tools, we've seen that already. It's certainly gone in with imaging, where 10 years ago, why are you showing the X-ray? Now these systems can crawl into the X-rays and actually give the information that we need and the measurements quite readily. It's certainly going to be impacting patient care more and more. But the challenges are going to be these technological limitations. Is like we may have more. How are we going to implement this in a cost-effective fashion? Certainly some of these are being monetized. So it's all well and good to take your forms and put it in to send it to Aetna and on ChatGPT, But some of the other ones, which are then inherent within Epic or whatever EMR system you happen to be using, are going to be proprietary. So then you have to pay for that. So who's going to be paying for that? And for both on the physician side and for the patient side. So, and lesson learned from legal is the importance of thinking ahead of it. It's like, oh, what is going to happen when this, if this goes wrong? So I'll finish up. We needed to build ethical guidelines, and I think this is what our societies, and especially spine, et cetera, as these start rolling out, we need to start, taking pot shots out and say this is not working. Identify hallucinations earlier on, because once the code gets put in, it's going to promulgate itself, for eternity. We need to prioritize patient welfare. I mean, how it really affects the individual patient. This gets back to some of the problems of what happens with genetics. And genetics has been great, but what are you going to do with patient? Who's going to tell that patient when they get their profile that they're at risk for getting dementia or some other disease process, BRCA proteins, et cetera. So we have to think about how we're going to roll that out to the patients. Again, transparency and fostering trust are the main things for this. And balancing patient safety has to be paramount when we see these patients. Again, a lot of what these systems can actually measure is easy, but we have to help determine what is actually important for the patient. Thank you very much.
Yes, please.
Fantastic session. I'm Christoph Hofstadter from the University of Washington. A question I have for you. I think Dr. Glassman's lecture really resonated with me, and the reason for that is, how do we get the granularity of data into the system, as we have so many different people involved, the patients, the hospitals, the payer, the industry. How do we get all this into a pot, and then how do we kind of like, as a society, then police that so that the outcomes are not totally crazy? So how can we, envision that?
Thanks, Christoph. Steve.
So I think, first of all, I look at it as we're going to do it incrementally, right? I think if we're going to solve in one fell swoop, like the machine's going to do it for us, making our data granular, that's not going to happen. But I do actually think that's, in addition to a challenge, a benefit for us, because when we've had sessions with payers and hospitals about data and what's really the value of the data that surgeons bring, if it's just administrative data, they really feel like they can get it somewhere else better. And the thing that will allow us to retain control as compared to payers and governmental entities is there are pieces of that data that only we can provide, making it more granular in terms of, like with the OR smart form, why are we doing the procedures, what's the intended diagnosis, what's the specifics. And in terms of proms, which now, you're seeing government regulation that proms are required now with hips and knees. The reality is they're going to be able to require the hospitals all day long. The hospitals can't get that data because it comes from the patients, and unless the physician, is sort of the champion of that and goes to the patients and encourages them, I think they're going to have a very hard time getting it otherwise. So I think it is a challenge for us, but I also think it's a leverage point for us that'll allow us to continue to keep, more control than people outside of our specialty would like over how this process runs.
Thanks, Steve. We'll go back and forth.
Yeah, Dean Chow, New York. I have a question for Rohade. Great talk, phenomenal. You've done extensive work in this area. A two-part question for you. So the first is, what would you recommend for us as spine surgeons, as doctors, as neurosurgeons, orthopedic spine surgeons? What do we need to actually do as surgeons to accommodate this change and how AI is managed? Do we need to do ChatGTP more, et cetera, et cetera? And then the second part is, what is your prediction of how what's the biggest impact AI is going to do to our field in the next 5 years?
Thanks, Dean. Rohade.
Thanks for that question, Dr. Chow. I'll answer the second one first. I think the biggest impact on our field, and I think we're just going to have to be wary of this, and it's going to affect our patients, is insurers and payers leveraging AI to prevent our patients from getting the care they need. There's already a substantial amount of evidence out in the public of commercial payers utilizing these tools to generate denial letters, retroactive denials. And I think it's going to take a kind of proactive and concerted effort on our end to counteract that in every single way we can. And so being up to date with the latest tools and advancements in this space is going to be critical for our specialty and for advocating for our patients.
Yeah, I would just emphasize it's a tool for good, but it's a tool for bad too. And remember, cell phones were supposed to make it so that everybody's on a beach and they do the work for you. It doesn't really work that way. So it's the possibility of negative actors in our field using it is so high. We'll keep going.
Yes, I'm Tran Moffat, neurosurgery. There's recent reports showing that United Healthcare, they're using AI to reject procedures at a rate of like 1.2 rejections per, a minute. And so what are we doing as an organization to kind of prevent this from happening? I know that in our area in Florida here, I recently just went up to Tallahassee and met with the senators and representatives there, and we're working on legislation to prevent insurance companies from using purely AI for rejections or of claims or retroactive denials. So what are we doing as an organization to prevent this?
So it's a great question. Yeah, Katie.
Katie Orico with the AANS. I can tell you one of the things that we're working on in Washington on a national basis, and I would say I think there is going to be some need to do this at the state basis. You're seeing a lot more legislation being introduced and discussed related to prior auth and utilization review, and that we've got a bill that we've been pushing for the past 6 years that we're close to getting across the finish line that's got a provision in it that is key, which is that any denial in Medicare Advantage, this is where we're focusing right now, has to be reviewed by an appropriately qualified clinician. So, those are the kinds of guardrails. I mean, we know that the plans are tricksy, so whatever we come up, they'll figure out a way to get around it. But that's one way we're trying to go at that to stop the pure automation of denials and require a human body to have to be part of that process.
And I would just emphasize for the spine section, this is a really important topic that takes a lot of effort, bandwidth. The whole leadership cares a lot about this. Lou Toomey Allen, Eric Potts, Juan Uribe, Erica Bisson, Dean, Zach, everybody cares a lot about this particular topic. A lot of effort goes into that. I think there might be opportunities for us to bring that more into the open potentially next year. But I think this is a really important question and something on everybody's mind in terms of how we, fight back against the things that already make our jobs harder, make things harder for our patients, and now they're going to be put on steroids because of AI. And so what can we do to fight back? It's got to be an organized effort. You can't be by yourself fighting this battle. We're all in the same boat.
Yeah, Mo, one of the things I think, can you hear me or no?
Yeah, go ahead.
Yeah, one of the things I think we're going to be focusing on in the future is going to be, so you train these models, right? So the battle is going to be over what source of information you're using to train that data, to train those models. So the insurance companies are going to want to use a set of data, and they're going to train their models utilizing that. And we're going to be trying to battle to say, okay, well, this is the appropriate location to find reliable medical information. And I think that's going to be a big battle in the future.
I couldn't agree more. Oh, sorry, go ahead.
I'll let you finish.
I couldn't agree more with that. And that's why it's so critical that we're always in a reactive posture, right? Because things get done to us and then we have to react to them. But it's so critical that we be proactive from a data perspective, from a scientific perspective, so we can defend the things that we do. In this moment, there's probably a dozen journalists working on a negative article about spinal surgery. And so we need to just assume that that's how it's going to be. You guys have seen the different rankings that come out about unnecessary surgery and things like that, regardless of how flawed their methodology is. But that's why we need to be proactive with some of the initiatives that Katie was talking about, and some of the things that frankly we have to do just to sustain the fight, to be able to take care of patients, deliver surgeries in a timely manner. I don't see any other questions up there unless there's anyone else. Sorry, the lights are very bright, so I can't see if there's anybody. One more. Okay, go ahead, please.
I have a question to the fact that certainly the medical and the regulatory agencies are at each other's throat. But when we face medical legal issues, is there any sort of AI that is in the process of being incorporated into the legal arena that would then be able to mitigate, and you have AI versus AI instead of AI versus with arbitrary rules that the legal profession is promulgating? And a comment to the effect that I think, more AI, the more we start to resemble Borg collective.
Sorry, that last comment was more AI, more what?
As in the Borg out of Star Trek, Borg collective.
Oh, got it. Sure. Jack, did you want to comment on the medical legal aspect?
Yeah, I think it's in flux. I mean, AI versus AI, one AI bot versus another AI bot on what was done. I think that whole body of law is going to be ever changing. Right now, they're just working on proprietary stuff as opposed to, who wins that article. I don't know of any case where that's come up, certainly from a diagnostic standpoint, where a diagnosis was made and a treatment rendered that was, quote, flawed, was then sued, and then they had something else. I'm going to go back to the other question from right before that, though. The natural language processing. So when I first started getting into registries, last name could, in 36 different registries, only 7 had last name in the same type code, L-name. And that was just for a name. And it was like all over the place. With these new learning models, you can actually tell it how you want that, like looking at a note. So instead of putting, again, we talked about this a little bit yesterday, putting that spondylolisthesis that you want to do a fusion on, it can listen to your note and also say spondylolisthesis, spinal instability, put all the codes in for it. So it actually can recognize that. Another thing that's going to be coming down the road, like with teams and stuff like that, Stephen was alluding to with ODI, you're going to have to put in some like risk adjustment. So how many people put down all the different medical things that make up the Charlson-Elix-Howler comorbidity index? Probably not. But if you don't put that in, you're not going to rank order your patients. So these programs, I think once they get more technical, will actually put the appropriate codes in the appropriate boxes and get the specific level of, yes, it's spondylolisthesis, yes, patient's got radiculopathy, patient's got weakness, patient's got instability, patient uses a cane. Those are like 5 codes right there, okay? And I pretty much guarantee most people don't put those in, but that's how you beat them, because if you then cross-reference it against EviCore, you'll win majority of the time. So, but those programs can actually help us put that in a format as opposed to remembering all the different codes, which are, as Steve was alluding to, ICD-10 is, horrible. But they can't, that's where the bots, I think, will have a lot of pressure and put that in a cogent note. And then I'll make my informed consent off this, do this to Aetna, do this to United, et cetera, and put it and not have to remember all the different variations of it. But still do it looking at a patient in the eye and say, ma'am, this is what you have, sir, this is what you have, this is what I see in the films, and now it's going to be coded effectively. I think we have to learn how to use it effectively to play their game.
Basically, if you have any coding question, call Jack. Right, Jack?
Green does that enough, so.
Thank you all for attending today's Artificial Intelligence, How It Will Affect Your Practice session. Thank you again to the moderators and the speakers.